started, and I'm going to run through this one. So basically today's presentation, cellular supracellular lesions, which is quite a wide topic, with the cellular, as we know it, quite a very busy area within the cranium. That's basically an area overview of our university. I think the team of Colorado have already had a walkthrough tour. So basically the cellular is so the cellular is quite a very busy area, and basically anatomically described as an area that involves the anterior limit, which is basically the anterior clinoid processes, posteriorly limited by the posterior clinoid fossa. This is the cellular area. The paracellular area extends down to involve the dorsum cellular, which is part of the clivus bone, and anteriorly it will extend all the way to the cribriform plate, which is basically part of the ethmoid. See the cursor again? No. Right. So the cellular has a normal anatomical size, which is usually around 5 to 16 millimeters in the AP diameter and 4 to 16 millimeters in the vertical depth. These are basically the accepted normal sizes of the cellular. So anything usually out of these, you start begin thinking of maybe a possible pathologic process. So as well, infracellular, we have the sphenoid bone, sphenoid sinus, nasopharynx, and the clivus. For the soft tissues, we basically have the cavernous sinus on the either side of the cellular, which has all the neurovascular structures, including the carotids, the cranial nerves, 3, 5, and 6, running through. And the reason we are looking at all this anatomy is because lesions that we are going to be looking at of the cellular basically rise from these pathologies, rise from these anatomical structures. So we shall go down in a very systematic way for the next slides to see the lesions that are derived from any of these anatomical structures. And indeed, lesions of the cellular are quite variable, and several studies that have been done, including the latest 2022 publication in the Springer Journal, basically the epidemiology of common and uncommon adult pituitary tumors in the US, whereby a study that was conducted from 2004 to 2017 using the US database, the cancer registry database, that looked at the distribution of the different types of cellular lesions. And we know that there are some that are more prevalent than the rest, and pituitary adenomas were the commonest, ranging all the way up to maybe 63%, forming the commonest of that. So for today's presentation, we are going to try and dwell more on the common pathologies within the cellular and the paracellular lesion. So to help in diagnosing cellular or paracellular lesion, we basically have developed an approach, which is basically is to identify the lesion in the cellular itself. Is it in the pituitary gland? Is it in the cellular tussica, or is it outside the cellular tussica? Once you determine the epicenter of the lesion, then you know, is it really projecting above the cellular, or is it below the cellular, or is it lateral to the cellular? This gives you again a narrowing down to the type of lesion that you're going to be having. And then you analyze the lesion according to the imaging. The CT scan, MRIs, they have different characteristics, these different lesions. So is it cystic? Is it solid? Does it have flow voids? Are there calcifications? All these imaging characteristics help you to narrow down on the type of the lesion. Then with that, you can have the differential diagnosis. And again, like we looked at the anatomy of the cell and the paracellular areas, from the different normal anatomical structures, we raise the different pathologies. For example, in the pituitary gland, we shall have the pituitary adenoma, which is basically the most common pathology within the cell and paracellular region. And then the others, the differentials of that would be perhaps maybe Rathke's cleft cyst and craniopharyngioma. When you go down to the pituitary stalk, possible lesions that would raise from that would be the Rathke's cleft cyst, again, a craniopharyngioma, geminoma, eosinophilic granuliomas, and metastases. These are again all possibilities for lesions arising from this anatomical structure. The optic chiasm, most of the lesions will be gliomas and demyelination diseases. We go down to the hypothalamus all the way up, so we're moving from the cell itself up towards the brain. And the hypothalamus lesions that could be there would be the gliomas, hematoma, could be geminomas. And when we go to the lateral wall of the sinus, we have the carotid arteries, which can present with giant aneurysms, ectasias. We also have the structures that would run within the cavernous sinus, including the cranial nerves, so they can present with schwannomas, and they can have also inflammatory diseases and carotid cavernous fistulae. Around the cavernous, we know that it is invested by the meninges, so basically we can have also meningiomas arising from these paracellular regions. And when you go below the cell itself, would have structures that would arise from the sphenoid sinus, which is at the skull base, squamous cell carcinomas, chordomas down to the clivus, sarcomas, and metastatic diseases. So starting off with the commonest, basically, which is the pituitary macroadenoma, it forms about up to 63% of the cellular lesions and accounts for around 10 to 15% of all primary brain tumors. A recent Belgian report suggested even a prevalence of around 94 cases per 100,000 population in unselected autopsy studies, suggesting around 20 to 25% of the general population actually have pituitary microadenomas that may be asymptomatic. It's obviously very common in premenopausal women and very rare in the pediatric population, representing around 2% of all pediatric brain tumors. The imaging of the pituitaries, basically CT scan may show an enlarged cella because of the tumor. So there's bone erosion, remodeling of the cella turcica, different from what we've just seen, the normal cellar size. They may have a hypo dense if they have a bit of cystic components. They may be isodense to the brain, and also they are contrast enhancing. Calcifications are quite rare, in less than 2%. And of note, perhaps, is that for microadenomas, diagnosis of microadenomas, usually they are slow in taking up contrast as opposed to the normal pituitary. So when you give the contrast, they usually contrast towards the end. And that's how you can actually be able to differentiate the normal pituitary plus the very micro adenoma. Again, the size matters because the size varies with age, with sex, and also in the female population. It varies depending on whether they are childbearing or they are lactating or postpartum. Again, the Elster's rule, basically of 6, 8, 10, and 12, for both infants, men, postmenopausal women, and then women of childbearing age, and then lactating mothers, respectively. Differentials, basically we have pituitary hyperplasia, circular aneurysms, meningiomas, metastatic disease, lymphocytic hypophysitis, and craniopharyngiomas. Up to the next common pathology, which is a craniopharyngioma, that forms basically 6 to 10% of all non-glial tumors, usually benign but very locally aggressive, and arise from the epithelial cells of Rathke's pouch. It's primarily supracellular with only 25% into the cella, 75% above the cella. There can be two types, basically the adenomatous, which is more prevalent, 90%, and more prevalent in the pediatric population, and papillary craniopharyngiomas, which is more prevalent in the older population, and it takes up a more solid consistency. The prognosis for adenomatous histopathology is usually worse than the papillary, and it's even more locally aggressive than the papillary. That's what I basically just summarized. The calcifications more prevalent in the adenomatous as opposed to the papillary. So the imaging facilities basically there are calcifications. The mixed solid can be cystic, and it usually follows the 90 rule, the rule of 90, whereby 90 of them are mixed consistence, 90 are calcified, 90 enhanced. The papillary, like we said, rarely enhanced. And the CT, basically this is what you'll be looking at. Calcifications. Let's see the curve again. Yeah, so in the upper slide, you'll see like the CT scan with a lot of calcifications, the mixed densities, mixed intensities on the MRI, and contrast enhancement if it has a cyst. And then the histology slides below. On the left-hand side, the papillary, and on the right-hand side, the right for basically the adenomatous. Specifically for craniopharyngiomas, when you're imaging, MR spectroscopy is a very good cornerstone in diagnosing this, and basically what we're looking at is the lipid and lactate levels, or basically which is indicating a very high cholesterol index, as depicted by that image there, that peak. Okay. So this is very characteristic of craniopharyngiomas, lipid lactate peaks, and this is just because of the cholesterol and lipid components within the cyst components of these tumors, usually described as motor oil in most textbooks. The differentials, again, Rathke's cleft cyst, hypothalamic or chiasmic astrocytoma, hypothalamic hematomas, pituitary adenomas, dermoid and epidermoid cysts. The third most common cellular or paracellular lesion basically is the meningioma, which, as we all know, has very varied imaging characteristics, can be isodense or slightly hyperdense, very contrast enhancing. They frequently calcify in over 25% of cases, affect the nearby bone by causing hyperostosis. MRI, usually with a contrast, they usually have on the T2, they usually have a cleft, CSF cleft, because they are not invading. Most of them do not invade the brain parenchyma, so they usually have a good CSF cleavage, which helps in surgery. They do enhance very intensely with a durotail, which is one of, again, the pathognomonic features of meningiomas. Differentials, again, like we said, pituitary craniopharyngiomas. Rathke's cleft cyst is the next frequent, basically well delineated ovoid cystic masses, usually above the sella turcica, and basically with imaging findings, we find that the most pathognomonic feature is the claw sign. We know that most of them, around 25 to 30%, are iso hypointense. They are intracystic nodules in around 40 to 75%. But on contrast, the claw sign, which is usually resulting from the cyst compressing the normal pituitary, which enhances, can be seen on most of the images. So again, this is usually a remnant of the embryonic Rathke cleft. And on this particular scan, I think you can see the arrow of a claw. Because usually the cyst compresses the pituitary gland, and it forms, a claw shape. The imaging differentials, again, craniopharyngiomas that most are cystic or cystic pituitary adenomas, arachnoid cysts, and other neoplastic processes. So on our this was supposed to go. This is supposed to be a slide with a craniopharyngioma actually, showing basically why. Okay. Yeah, so the next common lesion basically is the epidermoids, which are usually eccentric. They're not midline. They are usually hypodense on CT scans, sometimes hyperdense, known as white epidermoids. Usually contain pearly white flakes as a result of discriminated epithelial cells and keratin and cholesterol. That's on the histology. The dermoid cysts are a bit rare, composing around 0.04 to 0.6% of all intracranial tumors. These are usually midline structures as opposed to the epidermoid, and usually contain all derivatives of the epiderm. Okay, so this we shall have hair in that. We shall have tissue on the histological slides. Okay. So the next is a hypothalamic. Oh. Hypothalamic hamatomas. Basically, these again benign lesions, non-contrast enhancing, and on the imaging, they usually have that characteristic collar button appearance. There you can see the arrow that is in between the superior arrow and the lower arrow. So that's collar button appearance usually described in the textbook. The other is a chordoma, which is a bit of a malignant tumor that usually accounts for 1% of lesions, arising usually from the embryonic remnants of the primitive notochord cells. Usually arise from the clivus, but again follows the 30-30 rule. So 30 of them from the spheno-occipital region, the 30 from the mobile spine, and 30 in the sacrum. That's usually the distribution of most of these chordomas. They enhance with contrast modestly. So that's again the distribution. And then imaging characteristics, they rarely calcify. So that's the clivus region. Okay, with those few slides, I think I've tried to compress, the lesions of the stela. There are quite many, and we couldn't really go into detail for each of them, as each of them is actually a very big topic on its own. But thank you very much for listening, and that's the end of the presentation. So I invite the next presenter. Good morning, everyone. I am Dr. Anacret Piamkama, and I'm from the radiology department of Mbarara University. I'll be sharing with you with regards to imaging of the cellular and paracellular tumors. Luckily enough, Dr. Blessing has done 60% of my work. So my work is going to be very simple because
in his presentation, he highlighted actually a lot of imaging. So I'll perhaps make an emphasis on a few aspects with regards to this. And so I will not review the anatomy, which you already discussed, but I will focus more on the imaging, a bit of the anatomical approach to diagnosis, and look at a few imaging characteristics. He shared with you this image, and it's very important to us in radiology as well, because for us to make a relevant description, we have to know those important points. Getting to know what you have and where do you have it. And of course, like he has mentioned, the pituitary fossa is a really crowded area and a lot in the neighborhood with the cavernous sinuses. So even something tiny can actually have significance clinically. So I will not go through this, but I'll go to how it would look on imaging. So we basically have three areas we're interested in. We focus on the pituitary fossa itself. And in the pituitary fossa, we are interested in assessing the pituitary gland, which we know, of course, would have two main components, the two lobes. The adenohypophysis, or the anterior lobe, and the posterior lobe, which is the neurohypophysis. And we know what each of these produces, mainly the anterior pituitary with focus on the trophic hormones, ACTH, FSH, LAH, and then prolactin, while the posterior pituitary is mainly ADH and oxytocin. And so I have got my MRI image here. It is a coronal T1 post-contrast. Okay, I'll give a little bit as a go-ahead on what we focus on when we are acquiring images of the pituitary area. So on this image of mine, what is labeled here, or where my cursor is, I hope you can see it, is where our pituitary gland sits in the pituitary fossa. This is coronal, so we've cut through it, and so you can be able to see either side of the pituitary with a stalk. Okay, and then on either side of the pituitary fossa are the cavernous sinuses. And within these cavernous sinuses, what we expect there are mainly really neurostructures as well as vesicular structures. So we'll expect there cranial nerves 3 up to 6. So with the exception of the mandibular division of the cranial nerve number 5. And these can be seen as these areas where you see low signal or hypointensity. Those are denoting the nerves within our cavernous sinus. And then, of course, we also focus on what is around the pituitary fossa. Superiorly, or in the suprasellar region, as well as on the sides like I've mentioned. So in the suprasellar region, we are looking at the hypothalamic region, because we know tumors that arise from there, which has described. You have part of the third ventricle, then the optic pathway, fornix, mammillary bodies, and then the sac of Willis. So, when we are doing imaging, we have two main modalities that we employ. MRI is the ideal and recommended. But because of some setups, and like you are in a developing country, some places do not have MRIs. So sometimes you'll have to find yourself with a CT at your disposal, and you still have to make sense out of it. Okay? But the ideal should be MRI. So, when we are imaging with MRI, we have dedicated protocol or particular sequences and views that we acquire to be able to appreciate the pathologies that involve the cellar and paracellar regions. So, mainly we do T1 non-contrasted, that is before we administer the gadolinium, and we acquire both sagittal and coronal views of the cellar region. And then we do dynamic contrast enhancement. What do I mean? We administer contrast and then image in a rapid sequence within a short time. Okay, acquire at 0 seconds, 30 seconds, 60, 90, 120, 180. And I will explain shortly why we do this. And then we also acquire delayed images following contrast administration. Then we can also have T2, specifically because these adenomas, part of the pathologies, tend to have hemorrhage within them, and it's easy to appreciate this. And if you have other pathologies involving the paracellular regions where you have vessels, you want to understand if what you're dealing with is a vessel or cystic structure. So if you have a vessel, you're going to have signal void, you have no signal coming out of it, and we'll show a few images. But of course, since we know sometimes the pathology is not only involving the cellular and paracellular, you want to also have whole brain sequences, and we can have axial flare, gradient echo, and diffusion weighted imaging. So, an overview of the pituitary anatomy, especially with regard to how we are going to appear on imaging. This is the grammatic representation. And like we said, within our pituitary fossa, we expect the adenohypophysis and the neurohypophysis posteriorly. And we have got the infundibular stalk here. Then superiorly, we have got the optic chiasma, and then we've got the third ventricle, and then we know we have the hypothalamic region here. So we try to focus. So how do these appear on imaging therapy? So I have got here a coned T1 sagittal MRI image. And on our MRI image, this is what we would see. This would be our adenohypophysis, the anterior lobe and the posterior lobe. So even on pre-contrast images, the neurohypophysis will appear hyper-intense. In other words, it is bright. We refer to it as the pituitary bright spot. And it's largely because of the contents of the neurohypophysis. Okay, we have ADH granules there that give us that signal. And of course, you can see the infundibular stalk or optic chiasma. Now, this pituitary bright spot is very important because sometimes we may not see it. And if we do not see it, we want to try and locate it, especially along the stalk. It could be ectopic somewhere, and we should be able to locate it. As you know from the embryology, the adenohypophysis and the neurohypophysis come from different regions, okay? From the diencephalon for the posterior lobe, and then mainly this one is from the Rathke's pouch, the adenohypophysis. So when we give contrast, or when we give gadolinium, so this other one is still a cone view T1 post-contrast sagittal MRI. Usually our pituitary gland enhances homogeneously, and you can see how bright it appears. You can equally appreciate the stalk here, and then our optic chiasma lies here. So he has highlighted a little bit on the size. This is crucial because we want to know if it is within particular dimensions, is it a normal one or having particular pathology? And this will vary with age as well as sex. Okay, if you're dealing with a male or if you're dealing with a female, if you're dealing with a child or if you're dealing with somebody who is in puberty, and he gave you the rule. But overall, unless one is pregnant, we do not expect it usually to go above 10 millimeters. You can see so in pregnancy where we have about 12 millimeters. In the young age group, males 8 millimeters, females 9, and then in puberty it's when you can reach 10, and in females it will be a little bit more prominent, and of course, as you understand, because of the activity it is doing, this is largely hormonal. So, when we acquire images, I have coned views here, T1, coronal, pre-contrast, and post-contrast here. And again, this is our cellular region. And our pituitary gland sits there. Okay, you can see what we have on the right and the left side, and then the pituitary stalk there. And then you can see our cavernous sinuses on the side. These round signal void structures are the internal carotid vessels. So, ideally, it should have a concave upper surface. So sometimes, even when you have subtle pathology like a microadenoma, that concavity is likely to change and maybe flattens or even becomes convex. So we want to usually appreciate that concavity and then try to measure from the base upwards how much does it measure or how long is it. And like we've said, we put into context whether you're dealing with male or female and which age group you're dealing with. And we start getting worried if you have anything beyond 10 millimeters. So, and when you give contrast, like I said, this is going to enhance homogeneously. And you can see our pituitary gland and the pituitary stalk are quite prominent and can be seen. So, he mentioned clearly that it is important, even as we do imaging, we try to localize. And when we localize, it gives us an idea of what kind of pathology we are likely dealing with. So you want to understand, do you have the pituitary gland clearly delineated from whatever you're dealing with? Okay? And is your pituitary gland actually within the sella tussica? Then, if you have a lesion, you have to localize it. Where do you have it? Is it within the sella? Is it within the paracella? Or within the suprasellar region? Because the differentials are going to be different. And then you try to appreciate what kind of signal are you dealing with. Is it something solid? Is it cystic? Or is it having actually mixed signal? And then, of course, other parameters like looking at the calcifications. And usually that will guide you to have an idea of what differentials you have. In radiology, sometimes we cannot come up with an absolute diagnosis because certain imaging features may be shared. But we need to give you the most likely differentials so that you have likely one of the two. And in certain cases, it is actually spot on because particular imaging features are a little bit unique. So, to highlight on this with regard to location again. So, we want to know, do you have it raising from the pituitary gland itself within the sella tussica? In which case, we are likely to expect an adenoma or cleft cyst or a craniopharyngioma. So we try to establish where is it arising from. He mentioned about the meninges. You have got the diaphragma celli, and meningiomas can arise from this. We try to examine the stalk and see whether it's rising from that, in which case you could have a Rathke cleft cyst, a craniopharyngioma, geminoma, or even metastasis. And then we want to understand, is it involving the optic chiasma, because you can have optic gliomas, or is it within the hypothalamic region? So these are important, and it is crucial that we actually can localize the lesion. Sometimes it will be difficult because there are extensions, because it may raise within the sella and extend within the paracella or suprasellar region. Okay, so that presents some challenges. But at best, we need to localize where the lesion is. So starting with the microadenomas. So we said microadenomas are usually below 10 millimeters. Okay, that qualifies it as micro. And anything that is above 10 millimeters, then it becomes a macroadenoma. So what do we expect on imaging? I have got my COND T1 coronal MRI image here. So, if we have not given contrast, we've not administered the gadolinium, microadenomas are usually either isointense, meaning that they are sharing the same intensity as the rest of the gland, or hypointense, meaning that their signal is a little bit lower. And even on T2, they tend to be isointense, same intensity. So if you've not administered gadolinium or contrast, it may be tricky. Yes, you can look at a few issues, a few features like we've described. Maybe you've lost the concavity, you have increased the height, okay, you have a distortion. One side is higher than the other, but if they have the same signal, it may be difficult. So we go ahead and administer contrast. And when we administer contrast, there are unique features. Especially, that's why we have the dynamic contrast enhancement. Usually, following contrast administration, we expect the pituitary gland to enhance in series, starting with the stalk itself, follows the posterior lobe, and then the anterior lobe. Okay? It enhances rapidly. So within a short while, it is going to have got homogeneous enhancement. But with the adenomas, they will enhance slowly. Okay? So as we are acquiring images at 30 seconds, 60, 90, within 60 seconds, the entire pituitary gland will have already enhanced homogeneously. But if you have a microadenoma there, it's going to remain there when it is hypointense. Okay? And later on, as you proceed, by the time you reach 180 seconds, the whole of it will have enhanced, because even the adenoma will enhance, so it will be a little bit difficult. But again, as you acquire the delayed images, the contrast will wash out of the rest of the normal pituitary gland, while now the adenoma is still retaining some contrast because it washes out slowly. So it's crucial usually when we are doing imaging that we do these dynamic contrast enhancement images, because they can clearly help us. Even when we've not been able to appreciate the adenoma, as we do this series, we are able to see this. And of course, in this image I've included here, you can see this hypo-intense lesion here within the pituitary gland, in which case it was a microadenoma. I have included a few more images. So I said, sometimes all you have is a distortion of the anatomy. For example, when you look at this coronal T1 MRI image, you can see one side on the right is a little bit distorted and raised compared to the left one. And if you look closely, you realize you've got actually something that has a lower signal compared to the rest of the gland. Okay? So it is hypointense in a number of cases, even before you administer contrast. And following contrast administration, you can see how it remains hypointense while the rest of the gland, which is normal, including the stalk, actually have enhanced well. So beyond the microadenomas, we said if the lesion is more than 10 millimeters, then it qualifies to become a macroadenoma. So macroadenomas are large. These can be confined within the cell itself, or sometimes they can extend superiorly to the supracellular region, and even give some serious compression to the paracellular regions. Now, there are a few unique features with the macroadenomas. They are mainly solid. Of course, they can still have calcifications and sometimes cystic changes, but prominently they are solid. And unlike, for example, the meningiomas, like I will show you shortly, the pituitary macroadenomas tend to have this shape. We call it a figure of 8 sign. Why? You will recall that you've got the diaphragma celli superior here, which is a dural layer. So the macroadenomas are a little bit soft. So they will not even invade or try to displace so uniquely the diaphragma celli, but they will protrude through, and the diaphragma celli is still causing some indentation on it. So you have something bulging superiorly and inferiorly. So it will give you that figure of 8. Okay, as long as it goes through, when it reaches up, it can enjoy, but remains compressed. And this is also important because unlike, for example, the meningiomas, for them, they will tend to displace these vessels. Okay? They will just push them aside and do not even compress the internal carotids in most cases because they are soft tumors. And they tend to expand the cellar, the cellar tussica, rather than causing destructive features, much as sometimes you can have the invasive types. These are just more images to demonstrate that, and they tend to have a little bit of heterogeneity following contrast enhancement rather than homogeneous enhancement. So again, more images demonstrating that. You can see the T1 post-contrast, and you can see this insinuating a figure of 8. You have a lesion within the cellar that extends to the supracellular region with this indentation. And on the axial, you can still see the same lesion. So, how do we differentiate these from the meningiomas on imaging? He mentioned a number of features. And some of these features are, of course, what are similar to other meningiomas elsewhere, such as the dural base, because we know these are dural in origin, and they will tend to have a dural tail. Okay, if you have a look at this sagittal MRI image of mine, you can see this little extension like a tail. Because its origin is based on the dura, it will have that extension. Not always, but most times. And then, unlike the macroadenoma that is going to enhance heterogeneously, like all meningiomas or most meningiomas, this will enhance avidly, in other words, intensely, post-contrast, and quite uniformly. And of course, you can have hyperostosis as well. This is best appreciated on CT. So you have remodeling of the bone. You have some reactive thickening, which is hyperostosis on imaging. And so, while there may be similarities between the macroadenomas and meningiomas, we can tease out a few differences and actually zero on one and say, this is likely a macroadenoma rather than a meningioma. He has mentioned the craniopharyngiomas, mainly two types, the adamantinomatous type and the papillary type. The adamantinomatous type mainly being in childhood and papillary type in adulthood. How do we differentiate these two on imaging? The adamantinomatous type are mainly cystic. They can have a solid component, but the prominent part will be cystic, while the papillary type is largely solid. So what are we going to have on imaging, or when we do MRI? You are going to have, okay, I have my cone views here, sagittal T1 pre-contrast, and then we have one that is post-contrast. So you realize that pre-contrast, you have a component here which has a different signal to this one, okay? So this component is mainly hypointense. But when you administer contrast, it will have heterogeneous enhancement. So the area that remains unenhanced, meaning that it is cystic, okay? So you have a solid with cystic components. Now, if it is, of course, we have more images. This is coronal T2, okay? And then you also have, again, coronal T1 post-contrast. And I want you to appreciate the difference. So you have this lesion here, which gives you one part that is really having a high signal or hyperintense on T2, which will tell you it's mainly fluid. But when you do the post-contrast, the part which was fluidy now does not actually enhance. All you can see is peripheral enhancement, and then the other component just mildly enhances. Okay? Then just more images, axial for flare, T1 post-contrast, and you can see really a lesion that has heterogeneous enhancement and with cystic components. So that is usually crucial. And then we try to look for calcifications if we see them, and then make sure that we rule out the other features that are unique to the other masses, for example, that we've described for the macroadenomas and, for example, for the meningiomas. Now, the pituitary region is not also spared from metastasis. So you can have metastasis from different regions, be it from the lungs, from the breasts commonly, and these can go into the pituitary region. Chances are high that when you have metastasis in the pituitary region, you're also going to have metastasis somewhere else in the part of the brain, okay? And so with the metastasis, these can take up a range or different imaging appearances, from solid to cystic, okay? And if you have multiple lesions in different areas of the brain, and you also have a lesion that is invading the pituitary region, then you think it is more likely a metastasis than a lesion that is raising primarily from there. So aneurysms are also important. What do we expect on imaging? These we can do both CT and MRI. We know aneurysms are abnormal dilatations of vessel. And we've seen you've got carotid vessels within the cavernous sinuses, meaning that these can have those dilatations. But also at the base of the skull, you have the rest of the sac of Willis. So it could be from any of those other components. So usually, when you have slow-flowing blood, even on CT, you'll have a little bit of hyperdensity. Okay, it's going to be whiter than the rest. And most times, we tend to have calcifications. So you are having clotted blood here or slow blood. That's the reason on this axial CT, it is appearing like this even when it is unenhanced. And on the sagittal MRI, you can again see the appearance. I have included more images for T2 coronal, T1 coronal post-contrast, and you can see the signal void in the T2, meaning that you're not dealing with a structure that is just cystic. Okay? So you are likely having some flow there, and that's why you have sometimes have to do the T2, the reason I mentioned from the start. Rathke's cleft cyst, remnants from the Rathke porch, which is supposed to involute and just leave a layer of cells, and sometimes from these you can have cystic structures raising. The fact that they are cystic makes our life easier, okay? So you have a mass that is cystic in nature. On T1, we'll have the same signal as fluid, and on T2, we'll have the same signal as fluid or as cerebrospinal fluid. Now, unlike, for example, the craniopharyngiomas, because we say the adamant matous type, can also be cystic. But even when they're cystic, you're going to have some solid components in most times, and you're going to have a wall that is calcified in most times. But this is more of a simple cystic mass, okay, purely fluid content. And the signal intensity will be the same for as fluid on all the imaging modalities, okay? Be it on CT, you focus there, you can see that hypodense, well-defined lesion there lying within the cellar region, okay? So, you look at this coronal T1 MRI pre-contrast, almost appearing like a macroadenoma. But the difference now, the macroadenoma would have been solid, and this one is cystic, okay? So you can easily tell that you're dealing with a Rathke's cleft cyst. The other rare ones can have really a range of imaging appearances. Dermoids, epidermoids, teratomas, lipomas. He has mentioned a few features. And some will be a little bit unique. For example, the lipomas, it's fat. So we are looking at the signal of fat, both on T1 and T2. And we suppress the fat, then we see the signal has disappeared, meaning that the content is fat. So we think that's a lipoma. If it is, for example, a dermoid may equally contain fat, and you are looking at that sequencing. Okay? The teratomas will have variable sequences, signals depending on the content. And that's why on these different sequences, on T1, you see this mass lying within the cellar. It's largely really hypo-intense. On T2, it is having a higher signal, but even it's more of a dirty signal, as you can see. And then T2 coronal, the same diffusion-weighted imaging, you see fluid restriction. So at first you may think, maybe this is any other cystic mass like Rathke's cleft cyst, but you suppress the fluid signal and it retains the signal, okay? So it means you have some degree of diffusion restriction, and that is important to help us understand some of these pathologies. Arachnoid cysts, a little bit trickier because they also have a cystic component. So this may be a little bit tricky to differentiate from the Rathke's cleft cysts, for example, because they can equally extend into the cellar, okay? And the intensities are similar to that of CSF with no diffusion. So on imaging, these are really tricky for us to differentiate from Rathke's cleft cyst. And then I think lastly, because there are many lesions really, but I'm trying to highlight on the common ones. We've said within the cavernous sinuses, you've got nerves, cranial nerve number 3, 4, 6, and then the ophthalmic and maxillary divisions of the of 5. So these can equally be lesions, but when we localize them, we are going to find them mainly rising from the cavernous sinuses, and there will be clinical correlation with their distribution and their supply, and this would have been described clinically. So on MRI, the intensity is the same. And when we do T2, they give us heterogeneous hyperintensity. So you are worried sometimes, could this be a meningioma rather than actually a schwannoma? But again, we look out for some features that will differentiate them from meningiomas that we already discussed, such as the dural tail, in terms of avid immediate enhancement, and these can be used to best and try to differentiate them. So, by and large, we've got really a number of pathologies that involve both the cellar and paracellar. And so we try as much as possible on imaging, try and look for unique features that can help us to differentiate these structures. And of course, where we are unable to come to conclusion, then we come to the aid of the neurosurgeons. They go ahead and have histology done, and you can make a conclusion. So briefly, that's what I will share with you regarding the imaging of the cell and paracellular region. Thank you so much.
Thank you, Dr. Gamakama. We'll next learn some about the medical management of pituitary tumors. The next speaker. Apparently, we'll have a change in the program. We'll now hear from Dr. Lillehei, Kevin Lillehei from the University of Colorado, diagnosis and treatment of acromegaly.
Okay, well, thank you for allowing me to talk, and I'd like to begin by thanking Dr. Blessing and Mbarara University for inviting the University of Colorado to come here. It's quite an honor for us, and our first international neurosurgery symposium, so hopefully there'll be more to come after this. So Dr. Blessing this morning wanted me to talk, he's going to talk about pituitary adenomas surgical treatment. He wanted me to talk a little bit about acromegaly, the diagnosis and treatment, and growth hormone secreting tumors are just one of a type of pituitary adenomas. So to give a little bit of a history, the first description of a growth hormone pituitary adenoma, which they didn't know was an adenoma at that time, was a description of a giant back in 1567. It wasn't until 1886 that Pierre Marie first described the syndrome of acromegaly. He described 3 patients at that time that had these acromegalic features, again, with no knowledge as to what actually caused acromegaly. It wouldn't be until about 20 years later that they discovered that there was a tumor associated with that, and it wouldn't be until 1910 until they made the association between giantism and growth hormone secreting tumors. So growth hormone excess can basically present in 2 different ways. One of them is being a giant, and the other is being somebody suffering from acromegaly. If you have a pituitary adenoma that occurs before when you're still in puberty, before your epiphyseal plates fuse. So when you're young, that growth hormone will lead to expanding growth of the bone, and you'll become a giant. The tallest person in the world, it was 8'11". He died at age 21. This was the all-time giant. And he basically continued to grow continuously until he was 21, and then died of sepsis from an infection in the leg. Now, acromegaly occurs when you get a pituitary adenoma that secretes growth hormone after your bones fuse. So you develop the tumor as an adult. And the features, I think we're all somewhat familiar with. It's that very coarse facial features. You get a prominence of the jaw, a large nose. You get growth of the jaw region shown in this lower here. You get a wide separation of the teeth. You get skin tags, excess sweating. So seeing somebody on the street with acromegaly, you can usually spot it pretty well. Sometimes it can be a little bit embarrassing if you go up to them and say, I think you have acromegaly. I don't necessarily advise that all the time. So what is growth hormone? So growth hormone is essentially a hormone secreted by one of the cells in the anterior pituitary gland, and it's under the influence of the hypothalamus from growth hormone releasing factor. It's secreted through the portal hypophyseal system to the pituitary gland. It promotes growth hormone secretion, and then it's growth hormone that gets into the blood and actually is processed in the liver. It stimulates a production of what's called insulin-like growth factor, IGF-1. And it's really IGF-1 that's the active hormone. That's what causes all the changes to the long bones, the face, that sort of thing. So it's IGF-1 that's the culprit. So what's the annual incidence of acromegaly? 5 per million. Males are about affected equally as females. It's usually a disease of middle age, around the 40s and 50s, and generally the diagnosis is delayed anywhere from 8 to 10 years in retrospect from the onset of symptoms. 95% of the tumors are benign adenomas. We do deal with some malignant growth hormone secreting tumors, and they're a real problem. But 95% are benign. They're mostly sporadic. Very rarely are they inherited. And the biggest complication of excess growth hormone, or the excess IGF-1 really, is cardiac. So if you've got a growth hormone secreting tumor, you're not going to live a normal lifespan. So you get the heart complications 30 to 50% of the time, high blood pressure, impaired heart function, the heart valve disease. The growth hormone does have an effect on the muscle of the heart. You actually get a cardiomyopathy, which is reversible. If you can bring the growth hormone to normal, that cardiomyopathy will improve. People get diabetes, high cholesterol. Sleep apnea is a real problem and often very unrecognized. About 60% of patients with acromegaly have sleep apnea. And then there's an increased risk of colon cancer. That's been an area that's been a lot of debate. All of our patients in the U.S. Will get a colonoscopy. We'll get a screening for colon cancer if they get the diagnosis of acromegaly. But I'm going to show you a little bit later, it's actually not all that common. Sleep apnea, 60% of patients have sleep apnea, males more than females. 2/3 of it's obstructive. Sleep apnea can give rise to a lot of medical conditions, including irregular heartbeat and heart dysfunction, and it does improve again with treatment. So here's a graph showing the incidence of colon cancer. We had it drilled into us for years that you always check a patient with acromegaly for colon cancer. Well, this is actually the increased incidence from the norm. So it's more common, but it's not all that much more common. If you have one of the familial adenomatosis polyposis, it's much, much higher. So how do you diagnose acromegaly? Well, really the best thing, again, is the IGF-1. Growth hormone itself goes up and down during the day. If you're under stress, depending what you're doing, you just exercise, growth hormone may be high. but then it comes back down again. IGF-1 has a very long half-life, so it kind of sums up what the excess growth hormone has been all through the day. So the IGF-1 is the best test for diagnosing acromegaly. And then once you're suspicious that they have acromegaly, a glucose tolerance test would be the next test that we'd recommend. In a glucose tolerance test, after you get a glucose load, your growth hormone should go down less than 1 nanogram per ml. So this is just a graph showing that if you happen to catch, this is a healthy adult on your left-hand side, if you happen to get the growth hormone spurt, it'll look very, very high. But in the acromegalic, it may be low. But if you sum up over the whole day, it's much higher, and that's what IGF-1 does. So IGF-1 is what you really want to measure. So pituitary growth hormone secreting tumors, 80% of them are macroadenomas, as we just heard from our radiologist, greater than 10 millimeters in size. 20% are microadenomas. When you evaluate a patient with acromegaly, you want to make sure that the rest of the pituitary gland is functioning properly because these are macroadenomas. They cause compression of the normal gland. And because they're large, as shown here, you always want to do a peripheral vision test as well, because a lot of patients will present with bitemporal hemianopsia. What are your goals for treatment of acromegaly? You want to control the growth and the mass effect. You want to preserve pituitary function. You want to prevent recurrences. You want to relieve symptoms, control the growth hormone and IGF-1 hypersecretion, and improve their mortality. So a pathologist, when we first started evaluating pituitary adenomas, we had the hematoxylin and eosin, or the H&E stains, and they're either red, acidophilic, blue, basophilic, or non-staining. Well, the growth hormone tumor was the classic acidophilic, the red staining tumor. So that was initially. Then we developed immunohistochemistry, where you could stain for the individual growth hormone on the tumor slide, so much more accurate. And then most recently, I don't know if you can see this on the slide, we now stain for transcription factors. And these are even more reliable. They're kind of a precursor to development of the actual growth hormone secretion. So for acromegaly, you always want to stain for the PIT1 transcription factor, and that'll essentially tell you that this is a growth hormone secreting tumor. Occasionally we'll have a tumor that doesn't stain for growth hormone, but it stains for PIT1, and so you know that it's in that class of tumors. Surgery is clearly the first line of treatment. Then we're going to hear about surgery from Dr. Blessing. It gives you immediate tumor decompression. It immediately lowers the growth hormone level. It restores the other pituitary function due to the compression. And potentially, depending on how well the resection is, it can be curative all on its own. And if it's not curative, at least it decreases tumor burden. So what are the remission rates for growth hormone secreting tumors? If you look at prolactinomas, okay, we have a medical management for prolactinomas. And we usually start with that. We can cure prolactinomas, which means put them in remission 70 to 90% of the time with medical management, about 85 to 90% of the time with surgery. And the reason for that is that these tend to be smaller tumors. In Cushing's disease, where 80 to 90% are microadenomas, we have a surgical cure rate that's about 90%. So very good. Growth hormone secreting tumors, acromegaly, we don't do as well. The cure rate with surgery is around 50 to 60%. With microadenomas, we're a little bit better, 70 to 80%. With macroadenomas, we're not so good. We're around that 50%. So this is one of the toughest tumors that we deal with surgically. And the reason that our cure rate isn't as good is if you look at this photo, here's the dura covering the pituitary gland right here. But if in this cartoon in the upper right, you see the tumor removed, normal gland over here, but they have a tendency for the growth hormone tumors to invade that medial cavernous sinus. And it's that invasion that you've got to get rid of to be curative. So we're tending to be more aggressive with growth hormone. We tend to do them all endoscopically, not microscopically, and the reason being is looking at that medial membrane of the cavernous sinus, and often you can strip that away and hopefully have a higher rate for cure. Pathology, all growth hormone tumors aren't the same. We now understand that there's densely granulated and sparsely granulated growth hormone tumors. This chart down below, this is from our own series of patients, and the surgical cure rate with a densely granulated growth hormone tumor is actually 70%. It's pretty high. Sparsely granulated, only 15%. They tend to be more invasive tumors. The important thing here is that the densely granulated respond very well. Cases, they'll give about 30% of the time the tumor will actually shrink with the drug, very much like with prolactinomas. It has a lot of GI side effects, so it's not necessarily an easy drug to take. Vicimont, which is our second line of treatment, actually blocks growth hormone at the level of the liver. So it blocks the receptor in the liver. When you treat somebody with pegvisomant, the growth hormone will remain very high, but the IGF-1 level will drop very low. Expensive drug, but very effective. It's a daily subcutaneous shot, so it's a bit difficult to take. It does have its own set of side effects, but it tends to be very safe, as shown in a 5-year study with 700 patients. So here to kind of line things up, the third line of treatment is radiation therapy. And we only revert to radiation when we failed with surgery and medical management. We'll even go back to surgery sometimes before we'll go to radiation. Radiation is shown here, about 50% cure rate, but it takes about 2 to 3 years to get that. Here is shown some studies that less than 7 years after radiation therapy, IGF is normal in only about 10 to 20% of patients. If you go up to 10 to 15 years after radiation, about 60%. So it takes a long, long time to work. So finally, what about normalizing growth hormone? This is survival curves showing upper is the control for normal people. If you get growth hormone less than 1, with all the surgery, medical management, radiation, they will return to having a normal lifespan. If you let them continue to have an elevated growth hormone, you can see that the probability of survival goes down significantly. So, thank you.
Thank you, Dr. Lillehei. We now have the pleasure of hearing again from Dr. Blessing, surgical treatment of pituitary adenomas.
Right, as they set up, again, for the next presentation, I would like to introduce a very important person who just joined us today, Professor David Kitia. So Professor David Kitia has been my teacher, my mentor, and my friend for quite a long time since I joined this university, and he is the founder of neurosurgery in this institute. So thank you very much, Professor, for joining us. He delayed to join us because he was giving a lecture somewhere. And he is the head of neurosurgery division in this institute. So basically, to be giving a talk on surgical management of cell lesions. Again, that's an overview. So a brief historical perspective. Surgery of cell and partial lesions really a thing not of recent, but has been practiced by our past fathers, including the British surgeon who really did most of this surgery, known as Paul, as far as almost a century ago. And he first performed this surgery again on an acromegalic lady. We've had Professor Leahy talking about that. By that time, I think the treatment modalities were quite limited, so surgery was almost all they had in terms of treating this lesion. We note from this historical perspective that the trend has shifted. The paradigm has shifted from very aggressive procedures in the past to very minimal procedures in the recent past. And this has paralleled the development in the technology and advanced research, and also a better understanding of anatomy. To the recent surgeries in 1909, Cushing tried to go minimal with these surgeries to the stellar region by performing an extensive lateral rhinotomy approach by adopting again a sublabial incision. This was again further described in literature by Halsted. We go to 1910. Basically, this was the documented first endonasal approach with the submucosal transeptal technique that was first described in literature in 1910 by Hirsch. This was later popularized by Guillot in France and Hardy in Montreal. These were students of Hirsch. So the choices for surgery of cellular and cellular lesions are basically quite variable, and we shall look further at the slices, indications or guiding factors to which surgery you're going to decide for which particular patient. They can be both open surgeries, and they can be as well, so they can be transcranial surgeries and they can be transsphenoidal surgeries. So for the transcranial approaches, we have the teriano craniotomy, which has basically been described as the workhorse to the access to the anterior fossa and the middle fossa. We've got the subfrontal craniotomy, the subtemporal, and the slightly minimal supraorbital craniotomies. The transsphenoid approaches also have sub-variations, which include the scopic transsphenoid approaches, whereby we use strictly an endoscope. We have endoscopic submucosal septal pushover approaches, endonasal submucosal septal and transsphenoid approaches. Then we have sublabial approaches. And then we also have alternative skull-based approaches. This again, we are going to look down at what makes you decide what procedure you're going to do. So for alternative skull-based approaches include transbasal approach of the ROM. Like this morning we saw as images of a patient who would perhaps be going for such a procedure as a best alternative. You know, we always have all this armamentarium of procedures, and you can actually adopt more than one procedure for one patient. So there's also a what they call a EOPTOS, the frontorbital zygomatic osteotomy approach, and also extended transsphenoid approaches. So these approaches give you access to the cranium and access corridors to the targeted lesion, which can be the optical carotid triangles, it can be the subchiasmatic corridor, the translaminar terminalis approaches, the interoptic, and the caroticotentorial approaches, plus furthermore approaches if you're going endonasal. So what are the guiding factors? I think this is a very important slide that we need to conceptualize, especially our residents. The pneumatization, actually what should be above there is the pathology of the lesion. Okay. From the earlier presentation, once you come up with a clear diagnosis based on the imaging, even before you get the histology, it helps you decide on what type of approaches, because some of them will be better with particular lesions and lesion sizes. So the pneumatization of the sphenoid sinus is another factor to consider when you're approaching this. With patients who have well pneumatized sinuses, cellar-based lesions, benefiting more from transsphenoid approaches as opposed to patients who have not very good anatomical sphenoid sinuses. So the position and the tortuosity of the carotid arteries, and then the intracranial tumor extension, and the size and degree of mineralization of the cellar. Again, the cellar can be classified. Again, we look at this slide again, which is going to guide us when we're going to do transsphenoidal approaches. So according to the Hamburger classification, there are various classifications of the cellar itself. There is the pre-cellar type, which basically is, you can read them there. So there's a pre-cellar type, there is a conco type. The conco type definitely is a contraindication to transsphenoidal approaches. Then the one that are very favorable are basically either a complete cellar or an incomplete cellar. So once you have all this in the preoperative images, it again further guides your surgical approach. There are various studies that have studied the anatomy of the sphenoid sinuses, and basically we are lucky that most of the sinuses are the cellar type, which basically gives you access to or the possibility to work through the transsphenoidal approaches. Over 90% of them are cellar, and of those incomplete and complete cellar, which you can still adopt to this procedure, are almost sharing similar percentages at 43 and 47. So why we look at the anatomy of the cellar itself, or the characteristics of the cellar, is because we want to protect all the critical neurovascular structures around there. Depending on the cellar type, you can always have different degree of safety when you're doing these surgeries. So we see, like, for example, if you have a complete cellar type as opposed to maybe an incomplete cellar type, when you're looking at the wall of the internal carotid artery, the distance between the wall and the sinus, the wall and the vessel itself, definitely is always better with the complete cellar and versus an incomplete cellar. So basically, this one helps you to improve the safety of your surgery. So also the chiasm location helps you to determine what kind of procedure. There is always a prefix chiasm, a normal, and a postfix chiasm. There is also this whole classification of the tumor, the pituitary tumors. There's the Hardy classification and then the NOSP classification. These are basically to show you the extent of tumor extension from the cellar itself, going all the way upwards, and also the lateral extension. But the NOSP classification for tumors that extend lateral will be basically guided, knowing that for tumors that are grades almost grade 2, the endoscopic approaches can be tailored to tumors that are grade 2 and below. Okay, tumors that are extending to grade 3A, B, and that extend so lateral to the cavernous sinus and the carotid artery are very difficult to access transsphenoidally. We go to the open procedures. So the transcranial procedures, basically the commonest and very versatile that most of us have used is the Terriano approach. It also has a bit of variation in terms of the size. Okay, so there can be a mini Terriano approach, which is usually deployed in vascular surgeries, maybe clipping aneurysms. Then there's the lateral supraorbital, and then that's the purple one. Then there is the supraorbital, okay, which is basically again the minimal. And then we have the whole Theriano. All these are basically small modifications of what would be the Therian approach. We have the interhemispheric approach as well that can be used, that has not so much, has fallen so much out of favor for most of the literature. And once you open with the transcranial approach, basically the corridor that you get is both anterior and the middle cranial fossa, as the slide below. That gives you the view. Once you open the dura, you'll be able to see all those structures, the second nerve, the internal carotid, its branches from the MCA and the ACA. So this approach was basically popularized by Yasagil, who is a very internationally renowned neurosurgeon in 1976, and it is the most commonly used neurosurgical approach really. It gives you access to transsylvian and lateral subfrontal views. Usually to do this, you have to position the head of the patient in a 3-pinpoint Mayfield, extended 20 degrees and 15 degrees to the contralateral side, and then with the malar eminence as the most high position in the key field. And principally, most importantly, to open this is the keyhole, the McCarthy keyhole. Usually, when you press this keyhole at the frontosphenoid suture, which is basically 5 to 6 millimeters behind the 3 suture junction of it leads usually to more preservation of the lateral orbital roof as opposed to putting it more anterior as previously recommended. This is the most recent recommendation regarding where you're going to put your keyhole for the residents. And then, of course, it involves drilling the lateral wing of the sphenoid process. Sometimes, depending on the pathology, you can do an SCP drilling, and also you can always open the roof. It gives you all that ability to expose all the anatomy, including the oculomotor nerve. So usually, sometimes when there's too much pressure, you can either have a shunt in or a lumbar drain to avoid tension when you're doing this procedure. The advantages, basically, it provides very wide multi-directional access corridors, the corridors that we've just seen in the previous slides. Gives you access to both the anterior cranial fossa, middle cranial fossa, sometimes even going down into the interpeduncular fossa. The limitations of this is that visualization of the opposite side usually is possible, but usually comes late in the surgical field. So sometimes you risk injuring the critical neurovascular structures on the opposite side. It also has a very limited intracellular view, so sometimes you might have to combine this approach together with endoscopic approaches. And there's a very narrow window, usually to observe the perforating vessels, sometimes need for brain retraction. Oh, wow. Okay, so the transcranial approaches, the supraorbital. I think we're running short of time, so I'm going to try to rush through these. Supraorbital, basically, advantage is that it's very minimal access, very minimally invasive, so very good cure for the patients. But the problem is that it is a very deep, narrow corridor and very cumbersome to work with. The subfrontal, which basically involves taking off all the frontal bone, has very good advantages, which have basically a very wide view, but limitations, very aggressive surgery. It might involve frontal lobe retraction, which with all its complication, and also it can involve CSF leaking through the anterior cranial floor. That's the positioning for the subfrontal, and that's the axis that you see when you open that. So the optic apparatus all the way down to the pituitary stalk. The FTOS approach, basically this one, it helps to access tumors that are more lateral or paralateral and extending towards the anterior. And it can always be done as a single piece. It can also be done as a 2-piece or sometimes a 3-piece craniotomy for the FTOS approach. The transcranial approaches, transsphenoid approaches, which have those variations that we talked about, it is very preferred these days because of the obvious advantages, very minimal access, very minimal disruption of the anatomy, very good recovery rates, very short hospital stays. You have to be very well conversant with your anatomy of the nose, and basically, usually the key landmark here is the sphenoid ostium when you're going to do these procedures. So again, usually you have to make sure that you preserve the sphenopalatine artery, which is basically the main feeder to the nasoseptal artery, in case you usually want to harvest a flap during a repair. That's the positioning. If you're going to do a transsphenoid approach, either microscopic or endoscopic, patient has to be basically the nasal ridge is supposed to be parallel to the floor of the theater, and head turned to the contralateral side. In the middle there is the surgeon. On the left hand of the surgeon is the assistant, and at the back of the surgeon is the instrument nurse. So microscopic versus endoscopic, various studies have, looked at what are the advantages and disadvantages, but the major one really, the microscope, is that it gives you a tunnel vision, whereas the endoscope gives you like a panoramic vision. These are the major differences. But several studies in terms of achieving gross total resection, in achieving remission, hormonal remission, they've always really been kind of leveling or similar. So this is the major big advantage of the endoscope vis-a-vis the microscope. Various endoscopes we can use from 0, 30, 45 to so with the microscope, you definitely have to have intraoperoscopy usually to locate or to see the area of the cellar. Neuronavigation, if you have, is always a good adjunct to increase the safety of the surgeon. So that's a Jules microscope. And basically, that's a summary of surgical approaches to the cellar and paracellar lesions. That's a microdoppler. If you're doing this, usually use a microdoppler if you're worried about carotid arteries. The other is basically nasal preparation. These are details now of the transsphenoid approaches, but I think in the interest of time, we might have to leave this slide maybe around 7 slides. We can go through them. So nasal preparation, you have to always decongest the nose with adrenaline. The nasal approach can be monostril, binostril, or 1.5 approaches. Usually I approach it monostril, which is very good, advantageous, minimal. And that's usually the view that you see. The sphenoid ostium is always your key landmark. The surgical techniques, so there is usually divided into different stages. The nasal stage, which basically after you've opened, you have this characteristic whole appearance. Okay, and once you see that, down there is the keel of the vomer that you always need to take out. You have to always avoid coagulation of the septal mucosa to avoid anosmia. The second stage is the sphenoid stage, whereby you have to drill the sphenoid bone and open it to access the sphenoid sinus. Limitations, primarily usually the end of the sphenoid ostium, caudally the pterygo sphenoid synchondrosis, laterally the sphenoid ethmoid recesses. The vomer always, you have to always leave a small bit to guide you as a midline. So when you're in the cellar, you take off the cellar roof, remove the mucus, the mucosa. And sometimes some people harvest the mucosa and use it during the repair, but there's always a risk of a mucocele. Dura opening is usually variable. I usually try to open my dura in a U fashion and try to take out the tumor from the posterior before the anterior to avoid the collapse. But they can be variable. You can open in an X fashion. I find that one helpful when I'm doing the repair. So the tumor resection, usually from inferior aspect to avoid the collapsing of the tumor or the premature descent of the diaphragm. Then you have to be very cognizant of the risks, which is CSF leak, that are graded from 0 to 3. and the different steps of repair depending on what type of leak you've got. Okay. Thank you very much.
Thank you, Dr. Dr. Blessing. We now get another lecture from Dr. Luahai, Diagnosis and Treatment of Craniopharyngioma.
Okay, well, thank you all again. What I'm going to talk about is the endoscopic endonasal surgery for craniopharyngiomas. I apologize to some of our group who've already heard this talk once on this trip. But the craniopharyngiomas obviously is in the differential diagnosis of pituitary region paracellular masses. And it tends to be one of the more difficult lesions that we deal with. Dr. Blessing referred, to Dr. Harvey Cushing, who back in 1932, this was his description of treatment of a craniopharyngioma. The most forbidding of the intracranial tumors. To be sure, one may occasionally succeed in stripping out a thin-walled cyst, and examples of this have been reported, but when the tumor is partly solidified and calcareous, sad experience warns the surgeon to leave it pretty much alone. That was in 1932. Dr. Yassergill, again, Dr. Blessing referred to Dr. Yassergill, kind of one of our heroes in microneurosurgery, but in 1990 had about the same opinion for craniopharyngiomas. His statement here said, the neurosurgeon trying his utmost to effect complete removal of a craniopharyngioma by employing meticulous micro techniques to separate normal from pathologic structure often reaches a point in the dissection where to proceed further or to retreat could in the long term be equally damaging to the patient. And this is one of the most superb microneurosurgeons probably in the world. So craniopharyngiomas clearly are a formidable lesion. They arise from Rathke's pouch in embryology. They actually arise, the pituitary gland arises about 7 weeks gestation, and these craniopharyngiomas can occur anywhere along the migration path of the pituitary of the pituitary stalk. And I lost my pointer right here. I don't know. Yeah, maybe I can. Here we go. Get the pointer on. So craniopharyngiomas about 30% of the time can be purely within the sella. More commonly, they arise here along the stalk, but they can be anywhere along the migration of the Rathke's cleft cyst. So they can be in the third ventricle, they can be down in the sphenoid sinus down below. They tend to occur in two flavors: the adamantinomatous craniopharyngioma, which occurs almost all kids under the age of 20 will have an adamantinomatous craniopharyngioma. Above the age of 20, about 2/3 of craniopharyngiomas are adamantinomatous, about 1/3 are papillary. Dr. Blessing had shown in his slide the adamantinomatous craniopharyngioma. This is a pathologic slide of it on the right-hand side. Again, all children have this variety of craniopharyngioma. 50 to 86% of adults do. They're commonly calcified, so the presence of calcium tells you this is adamantinomatous. They're more commonly infiltrative, and they have this classic motor oil-filled cyst. So these tend to be more invasive than the papillary. Papillary occur only in adults, about 30% in adults. They rarely have any calcium at all, generally well circumscribed, and don't have the inflammatory profile that the adamantinomatous does. Here's a subfrontal craniotomy. Here's a retractor under the frontal lobe. You can see the third nerve on the right, the internal carotid, the right optic nerve, and this is a cyst of a craniopharyngioma pushing up from below. This is the wall, and you can almost see the cholesterol crystals in that cyst wall right there. This is an endoscopic view of a papillary craniopharyngioma, and you can see they're filled with this sort of mucinous, yellowish material in general. So symptoms at presentation, they tend to be slow growing. Symptoms usually predate the diagnosis by 1 to 2 years. Adults present with visual symptoms and signs of hypopituitarism. Children tend to present with the same symptoms, but also problems with growth retardation and sexual retardation, obesity and hydrocephalus, and this is primarily due to hypothalamic dysfunction. About 20 to 30% of patients will present with diabetes insipidus. Interestingly, if you have a patient presenting with diabetes insipidus and they have a paracellular lesion, it's not a pituitary adenoma. It's one of these other either craniopharyngiomas or inflammatory sarcoidosis, whatever, but not an adenoma. Hypothalamic dysfunction is one of the biggest problems with these tumors, and it can result in obesity, dyslipidemia, hyperinsulinemia, elevated blood pressure. So it's in young children, it's a real problem. So what's the treatment? The treatment, this is one tumor where I think you really need to have a multidisciplinary team dealing with this. It's not only the surgeon's problem, in kids, it's your pediatrician. In adults, it's your neurologist, your neuro-ophthalmologist, and your endocrinologist. We've gone through a real change in treatment. When I was a resident training, when you did a craniotomy for removal of a craniopharyngioma, basically the goal was to get it completely out, whatever you could do. And often that was associated with a fair amount of morbidity, not necessarily mortality. We then swung the pendulum way over to the other side, basically from our pediatric neurosurgeons, where they were just draining a cyst, biopsying, and radiating. With the endoscopic approach, we now have a better view of these tumors, and we're swinging a little bit back to doing surgical approach, trying to get radical resection if we can, if it comes relatively easily. If not, leave it and go with radiation therapy. So our treatment, our classic approaches to these tumors are either a supraorbital keyhole approach, which was described nicely by Dr. Blessing, or the transnasal endoscopic approach. If you look at the axis of these tumors, here's a tumor. This is a solid portion. This is a cystic portion. Approaching this through a transcranial route, you can certainly get to the tumor. The optic chiasm sits right where my pointer is. So you got to work underneath, around under the chiasm, and basically you can't visualize that area. Coming endoscopically gives you a very nice visualization of the tumor, the optic chiasm, and usually you can see right back into the third ventricle. Here's the picture of the endoscopic skull base that you see. Here's the outline of the pituitary gland. You see the paracellular carotid arteries on each side, the bone over the optic nerves, and here's the planum sphenoidale. If you're going to approach this is in this region right here is where craniopharyngiomas are. So if you're going to approach these lesions, you need to open the sella, but you also need to open the planum, and that's shown here. This kind of yellow triangle is the exposure that you need coming from below, and that gives you this nice picture on the right with the pituitary stalk in the center. That's the epicenter of where you're going to find most craniopharyngiomas. When we approach the tumors, one thing that we look out for is a superior hypophyseal artery right here. That's going to usually be on the anterior surface of a craniopharyngioma. You want to try to preserve that that vessel. It's usually either one reason being is that vessel supplies the pituitary stalk as well as the inferior chiasm. So sacrificing that can lead to further visual loss. And this is a good picture of an endoscopic view of one of our patients. And you can see these superior hypophyseal arteries very nicely on each side. You can see the optic chiasm tented superiorly. This is the gyrus rectus up in front with arachnoid covering the interhemispheric fissure in this region. So I'm going to show a video, but I'm going to show that at the end. Let me go past that to a couple more slides. So survival, a craniopharyngioma is, quote, a benign tumor, but they're not all that benign. They have a fairly significant morbidity with them. The survival, however, is around that 90% at 5 years and about 85 to 90% at 10 years. So you need to keep that in mind when you're taking these out. Mortality is about 3 to 5 times the general population. So let me go back to, let me escape out here. And hopefully that's showing. So this is a patient. Not getting it. This is just about a 3-minute video, and then I'll be done. Okay. So this is a lady that was first operated on in 2012 with this lesion in the suprasellar area. It was subtotally resected and radiated, and now she presents 11 years later with recurrence. So you're kind of stuck at this point. They've already been radiated. And here we are, subfrontal approach. We've removed the bone we remove the bone over the sellar region. And it's not showing it too well. But here we're dissecting away the cystic portion. The pituitary gland is down below the sucker. And here we're dissecting off both sides, looking for those superior hypophyseal arteries that we can spare those. This tumor, because of the radiation, is really tightly adherent. There's the optic chiasm. So it had to be sharply dissected away from the chiasm to get it free. Shown here, there's actually some calcification at the level of the chiasm as well. And here is your right internal carotid artery that you see very well. And the tumor is slowly dissecting itself away from that. Inferiorly, we're looking down. Basilar artery is down at that level. As we remove it off this side, there's the pituitary stalk. And the tumor is intimately involved with the stalk. So we had no choice but to to section the stalk. Patient already had diabetes insipidus. So that freed it from below. Here's the up above where the calcium is in this actually lamina terminalis region. So as we open this up, there's the pituitary stalk up above going underneath the chiasm. And then there is the entrance into the third ventricle. You can see here. So slowly loosening it up. This is firmer than we would normally have because of the radiation. We're coming across. There's a little blood vessel coming off the carotid that's feeding into this lesion that will coagulate here before we finish getting it completely free. Here's the coagulation. And then sectioning it here. So now we've got it free from the right side. And we're going to look over to the left, dissecting it off. That's the basilar artery right there posteriorly. And then the internal carotid artery on the left, you can see off here, we're taking it off the left optic nerve. And there'll be another little vessel that's holding it in to coagulate. And then getting it free here. Following removal of that, then you go through your reconstruction, which we don't have time to talk about, but you need a good reconstruction. The incidence of CSF leak over these has been, was high about 30% or so, but now with the nasal septal flap, it's come down to about 10% or so. So here, in this case, we used some fat to put in there. We used a little absorbable plate, which I don't necessarily use anymore. I just lay the nasal septal flap right over that. Okay, thank you.
Thank you very much. We now have the pleasure of hearing from Dr. Luis Cava, postoperative ICU management of patients with paracellular tumors.
That's good. All right. Well, thank you for giving me the opportunity to talk to you guys today. Thank you so much to Dr. Blessing for inviting us to this symposium. I was going to briefly, for the sake of time, talk about the management post PSS in the neurosurgical intensive care unit. Next slide, please. Okay, so there is a certain things that we use to as a precaution when the patient arrives to the neurosurgical ICU after having one of those procedures that you guys have been seeing, and this is a standard protocol in our neurosurgical ICU in order to prevent, complications such as a CSF leak or bleeding. We usually have our patients avoiding drinking from straws. We do encourage the use of saline spray when it's appropriate. Avoid nasal cannulas because of the pressure that they can actually, put on the sella. That has been repaired, and usually we use an oxygen mask when it's indicated and needed for the patient. Always avoiding, Valsalva maneuvers, trying to prevent them from having, severe cough, which can also, increase transiently the pressure inside the head and can cause, dehiscence of the surgical repair. And also inadequate bowel movement. If you have a constipated patient, you're going to have the same effect. So these are basically general, precautions that we take in every patient that has, sustained a transnasal, operation. Next slide. That was one. Okay, important considerations for this is also, other things that are going to occur or can potentially happen in patients that have this procedure. One of them is, like I mentioned before, a CSF leak. Other are endocrine, issues such as diabetes insipidus, SIADH, also hypopituitarism, and other endocrine disturbances. I want to talk about, a few of them, not all of them, but what is Joseph? There you go. What is your rate of CSF leak post TSS that you have observed while you've been training here? That's fantastic. I mean, that basically speaks of the technique that you use in order to prevent this from happening. But from time to time, you're going to see them, right? And sometimes pretty bad ones that may need other measures to be undertaken. So when you look at other complications as well, I think probably, of course, the more fear one is the carotid artery injury, of course. I don't think we have one of those in our institution in quite a while. Right? One a year ago. Oh, yeah, sure, I remember. Which they can definitely be really a bad complication, right? Because first you have to stop the bleeding, and then maybe you need to take the patient for a cerebral angiography in order to determine if there is any potential leakage of contrast or the formation of a pseudoaneurysm. And some endovascular interventions may need to be performed. Besides the ones that I mentioned at the beginning, other potential things that could occur is infection, meningitis, which probably will occur later, in the course of the post-operative period. So, speaking about CSF leaks, the problem with keeping a CSF leak going is basically the risk for infection and also intracranial hypotension, right? That's something that the patient can have, a rate of 3.4%. And patients with a bigger, cellular or paracellular lesions, the ones that invade the cavernous sinus, can also have an increased risk for developing these leaks. And also if you have an intraoperative leak, it's something that can continue, potentially get worse. So basically, there is several considerations that you need to take into account in order to manage a CSF leak. Maybe Joseph, maybe you can tell me if you do have a CSF leak. Let's say you have a faucet, coming down the patient when they bend their head down, and what do you usually do to manage it?
Normally, what you have been doing is to mainly rest the patient in the bed, lying spine flat. Then, obviously, we try to prevent any kind of salva maneuvers. In case maybe they have a cough, we can treat that. We rarely give fluid antibiotics unless it is needed. Yeah, and most cases, like over 90% of the patient, over about 72 hours, the CSF will stop. Most cases. Yeah.
Okay, thank you. So this is just a list of things that you can potentially do, going from the more conservative to only operative treatments, including taking the patient back to the OR. Another thing that you can potentially go forward. One more. Thank you. Yeah, absolutely. What you mentioned, and you're right. As far as the antibiotic coverage, that only in very selected cases. Not necessarily from the get-go. And also, sometimes if they do develop pneumocephalus from the leak, you can use high concentration oxygen in order to improve it. But you mentioned every single thing there. Another thing that can potentially be done, I don't know if you guys do it here, it's not uncommon that when there is a bad leak, we place lumbar drains in our ICU in order to prevent, to have some CSF diversion and also release or alleviate the pressure on the surgical repair. And we keep it there, for a few days. We most often than not drain a fixed amount of, of CSF depending on the patient's symptoms. If the patients, have a bad headache when you're draining them, that means that you're taking out too much, right? And then we adjust that progressively over the next few days. Is that something that you use here?
We rarely use lumbar drains really. What we normally do in case the other things are failed, we can sometimes tap. We can do lumbar puncture, maybe tap about 10 to 20 mils as well. Most cases, it also stops there.
And that's a very good strategy as well. From time to time, Dr. Lily has asked me, okay, can you just do a high volume tap and see how the patients do? And if that recurs, then we go for the lumbar drain. But, yeah, absolutely doing a lumbar tap is, is appropriate. Forward, please. Okay, pneumocephalus, we talked about this already, 100% oxygen, kilobath to the degree, so nothing new there. Next one, please. You can see pneumocephalus there, and that's being alleviated with oxygen, and on the other side, you can see, that you gotta be careful when you do lumbar drains, because if you drain too much, you can make the tonsils come down, and the patients are going to have neurological symptoms from that. I've seen especially some cases in which you have a spinal leak, of CSF, and they actually end up with cerebellar hemorrhages, and sometimes they can actually have some descending tonsils. So something to keep in mind when you do lumbar drains. Okay, and another one I want to talk about, and this, I'm pretty sure you have good endocrinologists involved in all of the cases that you guys perform. We used to call DI, now they call it albumin vasopressin deficiency, aka diabetes insipidus. It's not uncommon to occur by itself, but also along with the SADH. Sometimes it can present also in waves, right? The patient first develops a diabetes insipidus and then goes into SADH. So you're definitely going to have help, from the intensivist or from your endocrinologist in the management of this. But this is something that can keep your patient in the hospital for quite a period of time. So it's something that needs to be addressed in the proper fashion. So it's very important to have, strict in and outs. It's very important to follow your levels of sodium closely. And whatever your capabilities are, follow the urine osmolality or the urine speed gravity. Or you'll see what the urine looks like. If the patient has a folic acid, if it looks diluted, then they have a high suspicion, that the patient has gotten into DI, along with, excessive thirst and those are clinical signs that you can use. Next. So this is basically some diagnostic criteria. Like I said, your endocrinologist or intensivist will help you with this. As a neurosurgeon, just make sure that you keep an eye on it, that you keep yourself informed, because at the end, that's going to impact your hospital stay, like I said before. Next one. So basically, what we do is allow, free access to water for the patients to drink to thirst. And from time to time, obviously, we treat them with desmopressin. Or DDAVP, right? That basically allows you to, kind of regulate the system in a better fashion and make sure that the patient does not become extremely hypernatremic. So you can have, like I said, different phases. I think the one that I've seen the most in our patients when that occurs is DI followed by SADH. SADH is not as dangerous as DI, as you know, because they don't drop the sodium levels that much, and sometimes they actually discharge when they are so mild SADH and they follow up with the endocrinologist or with us, shortly afterwards. Next. So when they do develop SADH, then, fluid intake, sodium, urine osmolality needs to be monitored as well. And then a mild fluid restriction, can be used as well. And sometimes the patients go in that regimen home. Other endocrine disturbances, again, is something that you need to know. Not necessarily you're going to manage it we will help you with that. And so having your endocrinologist on board is really important. We develop especially adrenal insufficiency, which can be life-threatening. In that case, hydrocortisone or other steroid replacement need to be considered as well. So another thing to consider always, when the patients come back from the OR, another thing that we do is that we assess the visual fields, make sure that the vision is similar or improved in comparison to what it was in the preoperative period. Always be careful that when somebody that's acromegaly needs to be reintubated, it's really hard. It has happened to me a couple of times. Actually, one was really close to doing a surgical airway, but thank God we got a tube in. And always keep strict ins and outs for the sodium and water disturbances. All right. Well, thank you very much for the attention. And again, thank you for being here.
Thank you very much. Can we have all the speakers now come to the front for a panel for questions? Our esteemed radiologist here with us still? Or did he go elsewhere? Looks like he left already. Okay. So questions for Dr. Lillehei, Dr. Blessing, and Dr. Kava?
Thank you very much. First of all, Dr. Blessing for bringing this first international neurosurgery conference to Mbarara. Indeed, this is the first in our country. We haven't had this before. And of course, the visitors for coming to give us this conference and some skills after the direct lecture presentation. And then, of course, I will ask you later, but I think I can ask you now that you make it a routine visit every time you come to Muhimbili. You also make a loop to pass through here, and then you give us this. So to become part of the system of your presentations every year. About the surgery at the pituitary, Dr. Blessing didn't talk about the sublabial approach, and it is a preference to some of my mentors in Kenya. I trained in Kenya. They prefer to go sublabial all the time. So I don't know why Dr. Blessing don't talk about it. And then the issue of CSF leakage after surgery, or even in general, the management of this CSF leakage, I think, it depends also on where you are managing the patient from. If you're managing the patient from a low and medium income country, Dr. Sembata said we don't give antibiotics. We give prophylactic antibiotics. Why? Because the monitoring of patients in the low and medium income countries is very different from the management of patients in the high income countries. The monitoring of patients, of these patients of CSF leakage in the low and medium income countries is not as elaborate as you do it in high income. What one might talk about, that the feared complication actually is infection, meningitis, abscess formation. And when our patients are not monitored closely, you see a patient today, and then you see the patient the following day. meningitis will set in, and by the time you begin treating the patient, it will be late. Whereas on your side, patients are monitored very closely that the first sign of meningitis will be seen, and the patient given actual antibiotics. So you need, in some of these things, many of these things actually you need to talk about the differences in the low and medium income country approaches and the approaches in the high income countries. What is your comment?
I think that's an excellent point. Interesting. So when I started training, I started with the sublabial approach as well, and liked it very much. My criteria for using microscopic endonasal was if I could get as good a view as I could get sublabial, and I think it does that. So we transitioned over to that. But the sublabial approach gave you an excellent visualization. It was a little bit more involved, a little bit more complicated. The issue of the CSF leak, I think, is a great one. Interestingly, in our country, there's another factor that we're kind of encouraged to get these patients out of the hospital by 2 or 3 days. So kind of on the flip side of what you were talking about is often these patients are out of the hospital and at home when they may start to develop meningitis symptoms. So it is offset a little bit. If we were able to keep them in the hospital longer, I think we'd know that risk. If they're going to get meningitis, it's going to happen within that first 5 to 7 days, usually.
Thank you. Thank you very much, Professor, for those questions. And just to add to what Professor Lehner just said, the sublabial approach is very excellent. But again, also we have to be cognizant that it is a learning curve with it. If you've not really been exposed to it, basically the surgeon's preference also comes in. But yes, it is one of the approaches that we could deploy for surgeries.
Additional questions?
I have a question for Dr. Blessing. Just in general, at MUST, how many pituitary adenomas cases are you guys doing a year, and generally what breakdown of approach are you taking?
Thank you. Generally, in a year, because since I returned from my skull-based training, it's not so long ago, maybe around close to maybe 2.5 years, is when we've started doing this. But we've been doing an average of combined both private and the government, maybe around 15 to 20 cases a year. Most of them I go endonasal and endoscopic, purely endoscopic. Though we've had a couple that we've deployed transcranial approaches.
Other questions?
Thank you so much. I have 2 questions. I think there were 3. One has been asked. So the first one is, for these patients, post-op, the patients with cellular lesions, I've read a paper whereby post-op, the patient is okay, has no complaints, no complications. After some time, maybe a week, then they develop symptoms of diabetes insipidus or syndrome of inappropriate ADH. How best do you follow up these patients and for better optimization, and how can we really prevent such complications post-surgery after a week? Yeah, the other was about CSF, which has been talked about.
Well, usually when the eye develops, it develops, very closely to that POD number 1. There are some patients that definitely we have seen, especially coming back to the emergency department, like what I mentioned, where patients post-TSS get discharged during the 48, 72-hour period, provided that there is no other complication that has ensued. But if they do come back with that diabetes insipidus, it's not common, I will say, but if that does occur, it's definitely going to be more challenging to treat, in terms of the replenishment of fluids and probably the need of immediate DADP. And at that point, probably the patient is going to be extremely volume depleted and maybe in shock. So that's very. As far as follow-up, the follow-up that we have, if that occurs, the patient goes to, we have a system in which if there is something that the patient is not feeling well about, they call the department, the neurosurgical department, and they speak to one of our staff and they leave a message, or they call the on-call resident.
So about 4 or 5 years ago, this was a problem because you can't predict who's going to come back with SIADH when they go home. So our endocrine team, in hopes of preventing readmissions, we're getting a sodium level close to home, wherever they live. They get a sodium level 7 days out from surgery. That has decreased the number of admissions about 50%. It's not a cure-all, but it's helped. So our endocrine team will get that sodium level. They'll chase it down. Hopefully somebody will look at it, and that we can prevent some of these readmissions with hyponatremia.
I had one question for Dr. Blessing. So with the smaller tumors that are very hard to detect on MRI, so Cushing's, for example, what is your situation here? Can you get lab values, blood values? Can you get the pathologist to give you kind of in-time answers in the operating room? Or are you making a decision beforehand and say, I'm going to just take that side of the gland that looks a little bit more suspicious, or that side of the gland, and then do the surgery and then re-examine the patient?
Thank you very much. That's a very excellent question. Indeed, usually what we usually do for Cushing patients with microadenomas, we try to preoperatively get very high resolution MRIs. At the moment, the highest we have in the country is just a 3 Tesla. So, but we get pituitary protocols and we try to isolate that. If that's very difficult, which is usually the case, we try to go anatomically from the anatomy of the pituitary gland. We know where the SCTH producing cells are located, which is most anterior, and then we try to target that when we're going in for the surgery. We do not have frozen section services yet in the country, so that's a challenge. We usually have to wait and see the response by assessing the blood levels with the hormone.
Again, thank you very much. About those small lesions, there is another old test of pipetting blood from the petrosals on either side, and then you compare the two, and then you take the side where the levels are high. I don't know whether you have practiced that. Where did it stop, and when did it stop? And two, about the craniophryngiomas, they are really difficult lesions, and I think I've got it wrong sometime here when we try to reject all several times. And I have seen that for the purely cystic lesions, aspirations can actually temporize the patient very well. You put a catheter in there and you aspirate the content, purely cystic, and it can reaccumulate. You aspirate again, and I have seen several patients, some mature patients actually. I have cured them by that method. And then the old method of putting of brachytherapy, putting reductive, not reductive. Huh? Yeah, yes, exactly. In there, We even did a study with Professor Leland Albright. I don't know where it also stopped. So the management of craniofaryngioma is difficult, and I agree with the partial resection of these conditions because when you have taken away part of it, it takes long to come back to the original size to cause complications which it had before. And radiotherapy, I think, is a problem for us in the low and medium income country because we don't have the facility of that focused radiotherapy to the gland, and many times people irradiate the whole region, people irradiate the whole brain because they don't have the gamma knife, and we come out with bad complications. And again, these are children. How would you go about with the radiotherapy in these delicate patients?
Thank you very much, Professor. You've highlighted something which could have perhaps maybe skipped my mind. So petrosinus sampling, blood sampling, you need in order to help you locate where either side is a very, very important point. We don't do it in here, but I think it's a very good asset to help you locate, especially these microadenomas. The second question was the craniopharyngioma. I do agree, like Professor Len has said, always I think the current teaching is that we go as minimal as possible. I think we had a case which we did a couple of months ago of a 28-year-old nurse who had a craniopharyngioma. It's always tempting for the surgeon really to try and take everything, but I think being as minimal as possible and maybe placing in an Omaya where you can give your treatment is always the way to go. It was actually unfortunate we lost that patient because of complications in ICU. Again, that's a very big challenge in our kind of setup, monitoring, getting bloods in real time, getting investigations in real time, usually a very big challenge. So, Dr. Kava, when you're going to see our ITU team, these are some of the challenges you're going to find. So, we shall try to brainstorm each other and see how to find solutions that are fitting our kind of environment.
So the pediatric neurosurgeons have kind of been driving the very minimal approach. And one of the rules that they have come up with now, which I think is good, if the tumor extends back beyond the mammillary bodies, 2 or beyond, you shouldn't attempt to even try to do a gross total resection. If it's anterior to that, you probably will do okay. In kids, obviously radiation is not a great thing, but they would rather radiate than hurt the hypothalamus. So there's a lot of literature that it's choosing one of 2 evils, really. And radiation seems to be the lesser of the 2 if the tumor goes back beyond the mammillary bodies. Oh, you will. With radiation, absolutely. It takes 3 to 5 years, usually to come on, but a high percentage. But a lot of the craniopharyngiomas have panhypopituitarism.
All right. With that, thanks everyone for your time and attention. We're grateful to the esteemed panel for their lectures and their answers to questions. Let's give them all a round of applause.
Schedule, but very behind schedule. And for that matter, our tea break, we've made it so portable. It's a disposable cup. You can move with it and a pack of something to bite. marketing drugs in relation to neuro challenges that we may face as people in our communities. So I'll invite him to come in 2 minutes to speak to us. You can use the podium here.
Good morning, doctors. Myself, Parvinder Singh. I'm working as a country head for MSN Labs. So the product like Posamite that you have seen there, and the product like these are our products, Epnon, Dolvet, CV. I just want to give a brief introduction regarding our company.
To make quality medicine affordable and accessible to the people across the world, drove our founder, Dr. M.S.N. Reddy, to set up an API manufacturing unit in Hyderabad with just a handful of employees. Today, Dr. M.S.N. Reddy's vision has come a long way. Our ability to see things differently has made MSN Laboratories one of the fastest growing research-based pharmaceutical companies in the world. From a humble beginning, we are now a company that has hundreds of best-in-class APIs and formulations. The manufacturing units of MSN Labs are present in India and US, and it has marketing offices spread across the world. At MSN Labs, R&D has always been an enduring passion which enabled us to become a global entity. The fully integrated R&D center of MSN caters to both API and formulation research under one roof. It is equipped with state-of-the-art laboratories and cutting-edge technologies. The API manufacturing facilities at MSN are backward integrated, offering cost-effective medicines coupled with quality. Our facilities are equipped with modern reactors that are capable of handling high reaction volumes. Our modern reactors are automated with closed transfer system for manufacturing high potency APIs. Besides APIs, MSN Labs also manufactures various finished dosage formulations. MSN has a separate block with ultra-modern facility exclusively built to manufacture oncology and other specialty products. All our facilities are zero discharge and environment-friendly units. Our packaging lines are fully automated and are serialization compliant. The warehouses at MSN Labs uses computer-controlled robotic technology employed for efficient and error-free storage as well as transfer of material. MSN Labs today boasts of a diverse therapeutic product portfolio. This includes first-in-India generic medications. MSN's largest number of DMF filings stands as a testimony to the research skills and execution excellence we have acquired over the years. These, along with its various new innovations, have ensured that MSN Labs have progressively won the confidence and faith of the consumers across the world. Certified by renowned regulatory bodies, and bestowed with prestigious industry awards, MSN Labs is a clear front-runner in today's global pharmaceutical landscape. We at MSN believe that continuous learning is vital to succeed, and we partner with like-minded organizations to nurture skills. MSN special networking initiatives are a perfect platform for bringing industry leaders together to share knowledge and to connect with consumers. As a part of its initiative to give back to the society, MSN regularly organizes pre-diabetic detection camps, blood donation camps, and collaborates with various NGOs and helps patients through our compassionate medicine programs. In the past 15 years, MSN has grown tremendously, and the core of this phenomenal growth is our exceptional workforce, who are driven by passion to go beyond perfection. MSN Labs, making a difference to people's lives, one product at a time.
Thank you. This is all about my company, MSN. It is the largest DMA filing in US, that is about 50 plus. So this is just want to tell about the company. Yes, sir.
Thank you very much.
Thank you, sir.
And for that wonderful video. So we shall now proceed to the next session for the day. We have two surgeries. We have a fracture group of 28-year-old and images that we saw earlier in the morning. She's blind already, but she's having a tumor with a lot of edema. So I think the objective of the surgery is basically ICP, and of course obtaining the histological tissue for diagnosis. Then the second one is the Chiari malformation. So we have the ultrasound scanner on the other side of the hospital, so it's within the theater. We shall be able to access it and also be able to use it for the second case. We have one operating room at the moment, but with the possibility of having the second one shortly. We are still working on those logistics.
But again, as we walk out, because of interest of time, there's a breakfast prepared here, so you can just pick and move with it. Yeah.
There are few medicines are there. You can take it. Thank you.